name is Karan Dixit, and I'm a neurooncologist at Northwestern Medicine. So what we have here is a patient who at this time was 35 years old. Actually, a few years prior to this, he had episodes considered for seizures, and he had an MRI, which demonstrated a lesion in the same area. When they came to our institution, they came in what's called status epilepticus, having frequent seizures. When we got this imaging, we saw a non-enhancing expansile mass in the left parietal and superior temporal lobe, which localized to the patient's symptoms. He underwent surgery, a gross total resection. Pathology demonstrated IDH mutant 1p19q oligodendroglioma, Dobler grade 2. Given the extent of resection, we elected to observe the patient rather than prescribe any adjuvant chemotherapy and radiation. This patient was presented at our multidisciplinary CNS tumor board, and the consensus consideration was to follow with close observation rather than prescribe any chemotherapy and radiation, given the fact that he's young, doing very well neurologically, with no seizures after surgery, has multiple young children, and had a gross total resection. We consider him to be a lower risk profile where observation is a reasonable course. However, if there was a residual tumor after surgery, he had frequent seizures after surgery, or potentially older, then we would have considered a course of chemotherapy and radiation. And 5 years later, he's doing great with an MRI showing no evidence of any tumor progression.